Start, sir.
Okay. Good evening, ladies and gentlemen. Once again, welcome you all to the second session of this webinar. Today, we have with us Yuichi Sasaki. He is actually from Japan, but his education, most of his education was in USA. What I've seen is that he's one of the most talented strength and conditioning specialists. Plus, he also does a lot of rehab also. And I had a lot of interactions with him when we were working together. And his expertise was really good. And that's how I had an opportunity to invite him for today's session. So though it will be more on rehab point of view, but again, it's a part and parcel of a strength and conditioning specialist, as well as for a coach to understand various aspects behind low back issues and how to make the athlete to recover from these issues. So basically, Mr. Sasaki is a Master of Science, Sports Medicine and Athletic Training from Missouri State University, Springfield, USA, and Bachelor of Science Athletic Training from Florida Southern College, again from Florida. And presently is working as a professional experienced sports scientist in Euphoria. It's a company in Tokyo, Japan. So he does. He has been working also with as a rehab strength and conditioning coach, Toyota Auto. Then senior sports therapist, National Institute of Sports, Kuala Lumpur, Malaysia. He was associated with Malaysian national badminton team, and you know that very well that one of the world champion in badminton was from Malaysia, Lee Chong Wei. So he used to look after his part of his training. National Para and Track and Field team up to London Para World Championship. Assistant athletic trainer in Lee University in Cleveland, and athletic trainer and multi-sports health center at Houston in Texas. Assistant athletic trainer in Missouri State University and University of Houston. And to add to his qualification, he is a strength and conditioning specialist and also performance enhancement specialist from National Academy of Sports Medicine. He has also done ASCA level 1 and also Association of Certified Personal Trainer from National Strength and Conditioning Association. Has a level 1 in nutrition, precision nutrition, fundamental movement system, and BLS certified National Heart Association of Malaysia. Strong first basic kettle course he has done, and NATA Star Track leadership and also anatomy trains for manual therapists. So a lot of things he has certified himself, and that's how he is very good in his profession. So let us welcome Sasaki for his presentation entitled, How Can We Help Athletes with Lower Back Pain? Rehab from Strength and Conditioning Coach Perspective. Over to you, Sasaki.
All right. Thank you. Thank you, everybody. And thank you, Dr. Zaji, for the opportunity. And thank you, everybody, coming in and to listen to me. So I'm going to share the screen first. Is that okay? This is it. Can you guys all see the screen? That's great.
Yeah.
All right. So this is how can we help athletes with the lower back pain, rehab, strength and conditioning coach perspective. I'm Yuichi Sasaki, as I am introduced. So first and foremost, I'm a certified athletic trainer from the United States, which is sports physio equivalent, and also strength and conditioning coach. As Dr. Zaji told me, I'm a profession. I'm most likely helping athletes to get ready physically to compete And then if you want more, information, I'm really active. Started becoming more active in an Instagram. So please follow me. So my approach is more like medically oriented strength and conditioning, and this presentation is designed for physio and also strength and conditioning. So please bear with me if you are not having a medical background whatsoever. Uh, Hopefully this presentation is helpful for everybody. And I'm not going to talk about not so many new thing, very basics. And hopefully this is going to be the review session for many of you guys. All right, let's get started. Today's contents. First and foremost, general overview, causes of low back pain, and I want to talk about why our clinical reasoning as a clinician and evidence-based practice so important, and assessment, local and global approaches, and rehab plan, exercises, and corrective exercise strategies whatsoever, and then prevention and reduce chance to get low back pain again. Sounds good? Let's get started. So general overview. What are the general reasons why we have low back pain? It's many reasons why. Probably if you're a physician, physio, you guys all know herniated disc, nerve irritation, and soft tissues like muscle, ligament, and tendons, all injured, and then fracture also, all injured. And then if you have a previous injury and then didn't do any treatment or rehab, then it might be sensitive area because of it. And also we don't want to hope it, we don't want to see it, but it might be due to cancer or any systemic diseases, right? So there are many reasons why. Those leads to particular diagnosis, like herniated disc at the lumbar spine, L5, L4 level, or S1, L5 level whatsoever, or thoracolumbar fascia, damage, whatever it is. However, it doesn't tell you how we end up having low back pain. Probably if you are athletes, if you are previously athletes, or you are physically active right now, many times we think, how it happened, the lower back. We all of a sudden start having a lower back pain, and we just wonder how it happened. Hopefully, it's not a cancer, but it's least likely. But it's good to keep it in your head, and most likely we'll get to that. So another general overview. Cause of lower back pain. Let's say example is lower back pain due to L4, L5 disc herniation, irritating nerve. We just found out through the MRI imaging. And then it matches the symptom, like say athletes having a shooting down pain, downhill, either or both legs. However, it's always good to know what's going on inside of a body, right? L4, L5, unless we do MRI or X-ray, we don't know what's going on. And then it's always good to know what is causing the pain. But what we also need to know is how we got to the point that we have pain, right? That's AKA mechanism of injury. And then the reason why I'm very how can I say, putting a lot of emphasis on we just know through MRI finding, we just know what is causing pain, because it doesn't tell you how it happened. As I said, why we ended up having low back pain just because we have a herniated disc. MRI findings or X-ray findings notoriously giving us a false diagnosis or a false evidence. It's a sign, if you look at the scientific literature, it's sometimes very misleading, right? Because MRI or X-ray doesn't specify how it happened, when, how, or where. Because this herniated disc on the image, you might have had it maybe when you were 5-year-old kid. And then after 20 years later, something happened and started having a pain again. Started having a pain finally, not again. But it doesn't tell you in MRI. It's just tell you there. So we have to find out how it happened, when it happened, where, and so on. Or we might not be able to find out, but we can guesstimate at the best. But it's always good. So in order to guesstimate or find out, what we need to have is two things, I believe. If you're a clinician, physician, you already know. If you're coaches, that's how we think. So it's very useful to understand how physio and physicians think, like clinical thinking or reasoning or evidence-based practice. Those are the tools we use as a clinician to help athlete. So what is clinical? What is a clinical thinking or reasoning? Clinical reasoning is the sum of the thinking of the decision-making processes associated with clinical practice. It doesn't tell you anything, I know, but basically what it's saying is this is a thinking process we as a clinician have. How can we get it's a logical step we have to get, we have in order to come up with the best possible solution or best possible plan to help athlete or patient in a given situation. Let's say in a picture we have a low back pain patient, competitive adult patient, cyclist, and then we might gonna do MRI based on what we have, based on the data we collected. Like as a clinician, we take history as we always do the physical exam whatsoever. We collect data, right? Collect data, cues whatsoever, and then we take a logical step. It might not be step, but circle, like this circle, right? Or this step. It's basically saying showing the same stuff. What's the step we can take? Again, what I'm saying is, what's the step we can take to have the best outcome, clinical outcome, to help athlete? That's a clinical thinking. And also we need we all know, I mean, clinicians all know in this webinar, evidence-based practice or medicine, we all know that. But if you're not a physician or a clinician, let me explain. This is evidence-based practice of medicine is the current best approach to help patient, which has three pillars. What is it? One, best scientific evidence available currently at hand, and clinical expertise, which is our experience, and patient values and preferences, like athletes and or coaches preference, or if athletes are minor, like under 18, then guardians or parents preferences. So we have to consider a lot of stakeholders opinion, right? And then if you lay down those three circles, in the middle there is evidence-based medicine. This is the best practice currently we can do. Okay. The problems of evidence-based medicine is, how do you define best evidence? If you look down on the right hand side corner, we have a pyramid of called level of evidence. The best evidence we have is meta-analysis, right? There's a top. week or systematic review. That's the best evidence we can have. We all know that. But let's say, what if your athlete is top 10 in the world? You're, I come to think, I'll come to this conclusion. The best evidence or this meta-analysis might not be the best evidence for our current situation at hand. What if your athlete's, again, top 10 in the world? He's not general public. So in some cases, the bottom expert opinion might be the best evidence we can have, right? Dr. Zajer already know, he's been experiencing with a lot of elite athlete. Sometimes meta-analysis doesn't show anything, but maybe he might be able to find some expert opinion, or his opinion matters, right? So that's why, and also another problem is, what if your patient does not have any, or patient or athlete does not have any preference? We all love this athlete, like, coach, or hey, Saki, I'll do whatever you tell me to do. I'll do it. We love this kind of athlete, but sometimes they are the pain butt because they don't give us any feedback, right? They do everything we tell them to do. It's very hard. So we love those kind of athletes. They're the most loyal athlete we can ever ask for. But sometimes that's hard when it comes to rehab whatsoever. So that's why we have to have a logical step to help athletes, aka, as I shared, clinical reasoning. And so what we need to do is physical exam. We call it assessment in the United States. I mean, athletic trainer doesn't do, physical exam. We assess. I don't know why. I'm not expert of English language, so please don't ask me why. So through assessment of patient or injured athlete, we will come to the conclusion of what's the best possible reason for this current injury at hand. We have to ask some history taking, like, did our athletes have injuries before on the lower back? If so, what kind, right? Past injury or past medical history is still one of the most reliable indicator for because of increased risk for the future injury. We all know we started having a injury predictor model, but if we don't have any injury predictor model, then hey, past injury will do the job. Because again, if you go through the literature, then if you past injury, again, I can't emphasize more enough, past injury or medical history is still one of the most reliable indicator. If you have ankle sprain, you will most likely have ankle sprain again if you don't take care of it, in a professional way. And then not in a young athletes, or those athletes who are very enthusiastic or eager, usually not fully completing physical therapy session or rehab session or strength and conditioning session prior to fully returning to sports. They're also at risk of re-injury again. So we have to make sure they did we have to know what they did before, if they had an injury. I'm not saying, let's find out, what other clinician did wrong. I'm not saying that. I believe other clinician did what they could do at their best. We just hope so, right? Rather, I'm just telling, we just need to know what they did and where they were and where they are. right now. And then how did this current injury happen? Again, knowing the mechanism of injury helps us a lot in order to find out. So if is this due to direct contact or non-contact or gradual onset? Oh, if this happens, like probably this is a little window. If this tackle happened in front of you, and then this quarterback, hopefully you guys familiar with football. I mean American football, and then this is hopefully this big enough window. But if this tackle happened in front of your eyes, and then this quarterback or the not quarterback running back is injured on the lower back, it's very, very understandable for us. Okay, this is due to direct contact. Or versus if it's a gradual onset or non-contact, then it's very, very difficult for us to understand. If you're a physician, you all know this. Athlete just come into your office or physio room holding their low back and, hey Saki, what's up? What's up? I have lower back. I have a lower back. I mean, they have a lower back, of course. I have a lower back pain. Okay, what did you do? I don't know. That's what they all say. I don't know. I just had it when I wake up. And I was like, all right, now we have to assess, right? So we all have that kind of experience if you're a physio or a physician, right? And then assessment wise, I think this is based on my experience and also professional preference. But I love to divide our assessment into two assessment approaches: local and global assessment approach. Local imaging like MRI or X-ray or CT scan, whatever or ultrasound imaging, snapshot of a local anatomical structure, or lower back strength or range of motion whatsoever, is all local assessment, because you only assess lower back. That's the body part we are looking at, but we also want to look at the bigger picture. We need to know the global relationship of body, because human body doesn't move just parts by part. Human body moves as a whole. So let's get into more. Local approach, like we clinician, we all do: passive range of motion, active range of motion, resistant range of motion, or muscle, manual muscle testing whatsoever, and orthopedic, special test. And when we use orthopedic special test, we need to make sure it has high sensitivity. That's a tongue twister. And or specificity. What are those? Sensitivity is to rule out the disorder. If it's negative, we can confidently say they don't have it. And it's specificity to rule in that disorder. So if it's positive, we can confidently say this athlete has this, right? So, but the special test, downside of special tests is the specificity and the sensitivity, those are very, 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 very. So we have to combine together and then come up with the best clinical guess or clinical decision making. So let's say compression distraction test for SI joint pain, it has 70 to 90 specificity, so decent to rule in the sacroiliac joint disorder dysfunction. And in passive physiological intervertebral movement flexion, 99 specificity, good to rule in the spine instability. But we have to combine all those stuff and then come up with the good logical, clinical diagnosis, right? And this is where my expertise comes into. We I personally or professionally good at looking at the body as a whole. And then there are many ways to look at the body as a whole, like selective functional movement assessment or movement impairment syndrome assessment and Yanda approach. There are many. Find out what works for you if you're a physician or if you're a clinician, right? In this webinar, we're not going to go into detail because I don't want to bore, or it takes maybe a month to explain all those approaches. So they're there. And but I want you to understand, what I want you to understand is the theory behind it. There are theories to think about the body as a whole. Human body moves as a whole. The reason why I'm saying that is tensegrity theory and also regional interdependence theory. Those are the, excuse me, those are the theories, or two of the theories explaining seemingly unrelated body parts are connected in terms of movement. This is where we really have to understand our human movement. So the good examples are where eyes go is where head goes. Where head goes is where body goes. Probably, if you're, I mean, I've done, my mom always did that, because if I did as a kid something, bad, my mom picked my ear. Everybody has that experience, had that experience when you were a kid. Well, what are you gonna do? You're not gonna go left. You're gonna go right if your right ear is picked up. That's saying your head goes where your body goes, right? And then where shin directed is where the body moves. Those are the two good examples I found as a strength and conditioning coach to help athletes get better. And this is where the majority of compensation comes from. And then, have you ever checked shoulder when you help an athlete with lower back pain? This is a good demonstration of this guy I found on YouTube, and this helps me to explain more. Better. So this is shoulder flexion pattern, right? The first one is very, very smooth shoulder flexion pattern. Then he demonstrates second one, limited one. His shoulder is limited, and what happens? Sorry, I'll show you again. His shoulder is limited right here. His flexion pattern is limited for some reason we don't know yet. However, if he wants to bring his arm to the flexion pattern, fully flexed pattern, then what brain doesn't understand. All our body does is just complete the given task, which is at this point shoulder flexion. So in order to complete the shoulder flexion, body will compensate other body part, right? In this case, rib cage. If you see that, he demonstrated he tilted rib cage posteriorly, and if you tilt the rib cage posteriorly, what happened? Lumbar extension. Lumbar is already lordotic, right? But in order to complete the shoulder flexion, it's going to be in hyperlordotic position, and then that's going to cause lower back pain. I saw this case many times with different athletes, especially overhead athletes with a limited shoulder flexion pattern, or shoulder mobility or stability in general, because they don't know how to move their shoulder. They lost the ability to move their shoulder, like baseball player, volleyball player, or throwers in track and field, or it's maybe cricket. Maybe I never worked with cricket players, but probably many physios saw that before. So this is one of the example of, human body moves as a whole. And so, okay, we know many things about human body and assessment. I didn't go in detail, but because I only have a 45 minutes, I have to move on to rehab plan. What I'm really emphasizing in my rehab strength and conditioning strategies for the safe return is I have 3 examples. I'm gonna make sure athletes can, have a good head control, because as I said, where head goes, where body goes. Just like this rugby player, look, he is running in one direction and he is looking at a different direction. It's a huge, not huge, very difficult task as a human body, right? So I have to make sure he has a good head control, even though, and then as I said, another example, we need to have a good pelvic control or low extremity control, because where shin goes, where body moves, right? So in like this running back, where shin directing and in his eyes looking, he's going to shift to the right. So we have to make sure he has a neuromuscular capacity to do so. And also, we can't just, how can I say, babysit athlete, right? Of course, they have limitation. We have to go around that limitation, but after the physio session, they will live on to a functional world, physically complex world. Athletes, injured athletes, gonna be in standing, walking, or maybe running if they are, if they're about to miss the train or bus, they're going to be a little bit of, fast walk. So we have to make sure we prepare them to do so, right, as a clinician. So on top of it, we have to think about physical demand of the given sports. If athletes of collision sports like rugby and American football or Australian football, then we have to make sure athletes are ready to collide each other, and make sure we work with position coaches to get that skill back, how to tackle whatsoever. That's my realm of expertise too, and we're going to talk about it later, soon. So I also emphasize, when I'm making a plan, I really emphasize on framework, or not framework. This is those are the framework coming from the 16 consensus statement for the return to sports. So I use that a lot, and I explain more later in this presentation. For low back pain, I'm a fan of Dr. McGee in Canada. He's the authority of low back pain and spine biomechanics. I follow his low back pain strategy a lot. And he shows, in his book, he shared the 5 steps of low back pain rehab plan. As you can see, there's a 5 steps, right? And then, in my opinion, we can go back and forth these steps. If our assessment tells this athlete can go from step 1 to step 4, I would do it. But I'm gonna take this step first. Take this step 1, 2, 3, 4, very, how can I say, meticulously. I have to make sure they can have a good movement pattern, motor pattern, through corrective exercises first, in order to do strength. If, even though my assessment tells this athlete can build strength from day one. If they don't have a good movement pattern, I'm not gonna go there. They're gonna stay here. I'm gonna groove the movement pattern without any load. So don't think this is a set stone, steps. We can go back and forth, even though it's a day 20 or day 60 or day 90. If they have flare up lower back pain on a day at day 90, yeah, we go back to step one or step zero, assess again, right? And step one, movement.
So hip hinge against the wall. You're going to face this.
So we're gonna assess, identify, and then make a plan and try and reassess. That's the steps of step one. And three part of at this stage is help them to distinguish hip flexion from lumbar flexion, so as hip extension and lumbar extension. If you think I look younger, yes, I was younger. I was when I was making this video like 5 years, 6 years ago. I was having too many athletes, and I can't assess I can't help them, every day. So I send those YouTube video to them to do, make sure they do the movement pattern every day. And again, lumbar flexion and lumbar extension is usually the compensation patterns they use in order to create hip flexion and hip extension. So do check that too, and help them to understand how to brace the abdominal muscle. What is it? Make sure they can brace. How can I say? What's the good word? They can contract strength. They can contract, stiffen the midsection without losing their breath. Otherwise, they're gonna die, right? If they stop breathing. I always remind them to stop. Don't stop breathing, and help them to be able to do squat pattern. And in my opinion, they need to be able to do hip hinge too, which is pulling a hip backward without losing midline stability or neutral spine and knees going forward. And then step two, build a stability. Just a second. Let me mute. So build a stability while sparing the joints. What do I mean by that? Is make sure every joint does what they are designed to do. So it's called joint by joint approach. It's coming from Mike Boyle and also Greg Cook. Many of you probably know. Basically, what they're saying is human body is a joint stack on top of each other, and each joint has, again, as I said, specific function, which is either stability or mobility. Let me sip. Of course, every joint needs to have some kind of mobility and stability, but either one should be primary. So in the lower back, lumbar section right here, it needs to be stable. And then if this low lumbar section has a problem, whatever the problem it is, hopefully it's not cancer, usually one level up, like thoracic or hip joint, which needs to be mobile and also stable at the same time. This is kind of special joint we have. It only says mobile, but it needs to be mobile and stable. And or two levels up, like cervical and knee, which needs to be stable. They need to be stable. And if we do those, if we teach educate athlete's body to, do what they need to do, then we're on the right path. Where is it? Okay. And then step 3, endurance. And then in his book, endurance needs to be there, but the training exercise needs to last. Needs to last no longer than 7 to 8 seconds. In my experience, maybe 10 or up to 20 seconds, but longer than that, gonna cause them, just help them to make help their compensation pattern worse. So what I usually do, make my athletes do is 10 sets of 7 to 10 second on or 5 second off of hand plank or elbow plank or side plank. 10 sets, that's it. In the plank wise. And they always say, I prefer 1 or 2 minute plank. It sucks, try it by yourself. You will love it. And step 3, we're gonna finally, build a strength. Strength is I usually go 3 to 5 rep, and if we want to go high volume, I just gonna go increase the sets. That's gonna do the job for increasing the volume. And this I adopted this sets and reps scheme from NSCA. It's not a set stone scheme, but it will help you when you design a strength and conditioning program. The point is, if you manipulate sets and reps scheme, know the principle and basics, you can do those from day one. If assessment allows you, tells you you can do it, right? It all comes back to assessment. And step 6, that's where we have more fun, right? We're gonna have more power in producing power developing exercises like power shrug or dumbbell jerk. As you can see, develop strength first, and then develop speed and develop efficiency and then kinetic linkage. That's how you do it. And a focus on optimizing elastic energy storage and also recovery. That's very important. And probably many of you are physio in this webinar and then wondering, all right, where that manual therapy comes in, like massage, manual, spine manipulation, or even medication, or not even medication, but a therapeutic device like eStim. It's effective. I'm not gonna say it's not. I do all the time. I do manual therapy before exercises, just to how can I say, help athletes move better. But when we do manual therapy, we have to be very, very careful, because it's going to help us to have a more range of motion, right? More range of motion means they may not never or seldom experience that new range of motion. So our brain will go all over go nuts, go banana, and then come up with another compensation pattern. So we have to teach how to move, every time after manual therapy, or when we have no pain after eStim or ultrasound. That's very, very good, good chance for us, opportunity for us to teach better, movement through exercises. So it needs to go hands in hand. And medication, follow the instruction of physician. I'm not physician, so if you got a injection, you got to follow physician's instruction too. That's for sure. And prevention, I'm gonna show after this, and monitoring too. But consider all, it all depends on physical demands of the given sports, physical limitation of each athlete to complete the given task, traveling schedule and periodization, all the stuff, right? Consider all the things, personalize the program as much as possible. I'm not gonna say you have to personalize all the program. I'm not gonna say that. it's an ideal world. You know, Liverpool did all the, how can I say, personalized strategy. That's on news in Japan, but hey, it's a Liverpool. We all have limitation in our own practice. So as much as is enough. And so in the component is mobility, stability, motor control, strength and speed, and power. And this is a return to sports scheme I use. Return to participation, which is return to practice safely, and return to sports, which is return to compete in the game, and return to performance, which is hopefully after return to compete, they can perform better than before. This scheme is, adapted through that consensus statement on the 2016. And then I want to emphasize, I don't like timeline-based rehab. I'd rather want to use criteria-based rehab. What is criteria-based? We move athlete from stage to stage based on what they can do, not the time frame. Of course, time frame works on some injury like ACL return to sports, and then usually it's a 10-month mark, right? Before that, we have really, really high injury rate. And then criteria-based rehab, if you Google it, and a lot of our literature comes in, have at it, and I'm going to show what it looks like right now. But basically, it takes longer than timeline-based rehab, but it's going to have a lower risk of re-injury. So acute stage, what we can do is basically help them not to have a pain during the daily living. No pain during daily living, which is important for us to have in order to have a safe return to sports. I'm sorry, I'm going to go over time a little bit, maybe a few minutes. I'm sorry, I have 5 more slides or so. And acute stage, again, no pain during the daily living. So start strengthening a lot. And in this case, in this example, there's this rugby player had a cervical post-op, and then also had a low back pain. So what I started was, as a rehab S&C, is strengthening his low back pain immediately in appropriate position, maybe band, open kinetic, closed kinetic, whatsoever, upon the discussion with physio. And next step, those are all criteria and how to monitor that progression. And this is the function. Next is the functional stage. When we can have more fun, which is strength training, and those are all criteria we have, and checklist, of course. Okay, we can have, belt squat or hip thrust in order to help them to incorporate strengthening squat pattern, and also hip extension pattern, and then weight monitoring, how much they lift, or other tests like a running test, and the GPS was and GPS monitoring helpful too. And then return to participator 1, able to practice at this stage, of course, with restriction. Athlete at this stage, this athlete with lower back pain can lift weight with no restriction, and has started return to run with GPS, of course, monitoring, and has started return to contact because he's a rugby player, and has started joining the low skill passing drill, but no contact allowed. So they can do weightlift. I mean, at this stage, he's fully on me doing snatches or rollers, push whatsoever, and those are the criteria. And if they pass, last stage for me, return to participate, return to practice without any restriction. We can now, my job is done as a rehab S&C. After the discussion with an S&C coach and high performance manager, and at this point he completed return to run and return to contact and passed all the criteria he needs to pass in order to practice without any restriction. So, and then those are the criteria I created for him. So acute stage, functional stage, return to participate 1, return to participate 2. Of course, there is a return to compete, which is return to sports, and then return to perform, which is compete in a better performance level than before. And those are the reference. I'm sorry, I go over time, maybe a few minutes, but those are the reference. And now we have a Q&A session, Dr. Zaju.
Yes, thank you, Sasaki, for a wonderful presentation. It was quite informative in terms of the procedures basically you have been following, and I think you have shown a lot of videos also. So those informations are quite vital for people who have been involved in rehab part from strength and conditioning point of view. And I think it helps even the coaches also to understand basically what are the procedures and ways in which the athlete needs to come back to the sport. So sometimes in a haste, coach also pulls the athletes very fast back into sport, and that leads to further injury. So this is the place where actually this, the clearance part from the rehab and strength and conditioning specialist is an important factor for safe return to sports, I feel. Okay, and now I open the floor for questions. So if you have any questions, please do pop it up in the chat box. And
should I stop here?
Sasaki, yeah, and I think so Mr. Sasaki will get back to you on this.
Okay.
Okay, there is one question from Vivek Samania. In your opinion, core exercise is how much helpful in lower back pain?
It's it's very important. I mean, core exercises is helpful. That's given. It's been studied so many years, so many informative articles there. I think I always use core exercises as a preventative mechanism, but at the same time, it's not always plank. It's not always plank. For core exercises, there are few components I incorporate: anti-rotation, anti-lateral bending, and anti-extension. Anti-rotation is resisting the torque athletes himself or herself creating, or when they contact it, they can they resist, or that kind of ability. And also anti-lateral bending is can they resist the force which forcing them to bend laterally. Also anti-extension, which is as I show you, whenever we do shoulder flexion, if we have a limited shoulder flexion pattern, then rib cage flare up, which means core didn't do any job to hold the rib cage down. So I incorporate those 3 components: anti-rotation, anti-extension, and also anti-lateral bending, which many times cannot be done solely through core exercises. Sometimes we have to use squat. Sometimes we have to use farmer's carry or suitcase carry. Many other exercises. So we have to be able to be creative. So core exercise effective? Long explanation to the short answer. Core exercise effective if he is in the early stage of the rehab, and if he doesn't know how to brace their midsection, but it's got to be, progressively, how can I say, progressively challenging for that athlete in order to return to sports.
Okay, there's another question from Anuj Kapoor. So he's asking how to improve nerve pinching in lower back.
Nerve pinching.
Yeah.
There's a good article. I mean, one of the good exercise I usually have my athletes do is McKenzie press ups. McKenzie press up. If you look at McKenzie press up, is like a downward facing dog, and then we have to know which way our disc herniation go, anteriorly or posteriorly or laterally, left and right. We have to know it, but it shows a good indication that McKenzie press up against the wall, against the floor, on the floor, showing the good clinical results. So I recommend that.
Okay, this is not related to this, but then a bit of psychological aspect. This is asked by Dr. G.P. Goswami. So in our earlier place of work, I think you must have had a lot of work done on psychological aspects also. That means when you are as a team of return to play program, we had also some psychological sessions by some of the psychologists. So what is their role as a part of the team? Could you explain what they were doing as that's what kind of counseling they were doing as a critical rehab for the critical rehab program?
So if I understand correctly, let me rephrase. So they want to know, this person wants to know what's the role of clinical psychologist or sports psychologist in a rehab session?
Yeah, clinical psychologist. Yeah.
Okay. Well, first and foremost, mental health is very important. So clinical psychologist needs to be in the rehab process all the time. For me, in my opinion, it's traumatic at first for athletes not be able to compete. It's very, how can I say, damaging for real in his identity, because many athletes identify themselves as an athlete, right? They take pride in their craft. So how can I say, if once injury happens, that identity will be taken away. So most likely athletes will experience depression, right? Heavy, light, I don't know how to assess it, but clinical psychologist needs to be there. That's why I'm saying it. Depression most likely happens. And then if it's severe enough, he needs to retire from sports, right? That sports he or she loves, or the means to put a food on the table. So he needs to have a grieving process, acceptance process, those psychological steps he needs to have. And then if clinical psychologists are there to help guide that steps, grieving, acceptance, and new life whatsoever, then that'll be great. So I think those are the few functions clinical psychologists can have. I think there are more they can do.
Okay, there's one more question from Mr. Wazir Singh. He's an athletic coach. Lack of flexibility, especially in hamstring, hip, and back region, may be the reason for low back pain. So what is your suggestion on that? Whether is it because of this or maybe
So the lower back pain probably due to hamstring flexibility and then lower back flexibility. That's he asking.
yes, yeah.
Okay. So one of the two, there are many reasons why lower back pain has, I mean, we have tight lower back muscles and also tight hamstrings. Many times I see in a track and field, on a track and field athlete, maybe sprinters, in many cases, our pelvis or hip bone, hip joints usually tilted, excessively. If we have excessively tilted anteriorly, if we have anterior tilted pelvis, hip, then attached muscle, in this case hamstrings, will be stretched out. And if we have stretched out hamstrings all the time, that's going to be tightened up. Okay. So that's one of the reasons why we have tight hammy. One of the reasons. Okay. And other reasons, tight hammies, and also lower back pain, because it's going to, if you tilt the pelvis anteriorly severely, automatically put lumbar into hyperlordotic curve. So that's going to shorten the lower back muscle, and then that's going to be the recipe for lower back tightness. Also, athletes having the lower back tightness is one of the reasons is they might not have the good hip extension pattern. They can extend hip naturally or appropriately. So from the glutes muscle. Glutes muscle are usually the prime extensor of the hip and most powerful. And if they don't have it, if they don't have that pattern, then what's going to happen is lower back muscles and also hamstring muscles need to work more. So that's why hamstrings and also lower back start having tightness. So there are many reasons why they cannot have, hip extension pattern, good hip extension pattern from glutes, but usually I'm going to go for hip extension patterning, just like, the lower back pain rehab step 101. And of course, if you do assessment thoroughly, they might just have hamstrings, just tightness. It's not flexible enough. That might be also a case. So it comes down to how we assess. We can't just assume it's just tight, flexibility issue.
Okay, there is another question from Krishna Das. Thank
Yes.
you for spending your valuable time. That's one way of appreciating you. So he is asking, the question is like this: during acute and chronic low back pain, using physiotherapy, what is the ideal frequency of therapy session per week?
Good question. If the physiotherapy, if let's say team setting, if it's team setting, like if you're working with professional team or college team, you're going to be there all the time, then every day would be the best, right? If I'm with an athlete and if I'm in the team, then yeah, every day would be the best. But I understand, it depends on insurance policy. It's notorious in the United States too, so as in Japan. So yeah, I understand the pain. For me, as much as as often as possible, that's all I can do. Ideally every day, if you can see the athlete and the insurance policy covers. So that's why we have to educate athletes. That's why we really need to educate athletes within a given time frame. It might be 10 minutes, it might be 30 minutes, it might be an hour. And that's why I made a YouTube video. Hey, do this exercise on your own. It's not enough, it's not ideal, but it works. Yeah, that's a pain frequency.
All right, this is a question from Harpreet Singh, athletic coach. Is it possible arterial occlusion pressure training for lower back pain?
Sorry, what's the
He's
question?
asking whether we can do for arterial occlusion pressure training for lower back pain.
The blood flow restriction.
Yeah.
Blood flow restriction. I think I never used it. Blood flow restriction before, professionally. So I can't answer much, but that's a possibility. To be honest, I usually see that for ACL. ACL rehab, part of the ACL rehab, because quad is going to be atrophied. So it's beneficial for those atrophied muscle many times. But I don't know how to, restrict the blood flow for the lower back muscle. So and also it's a probably limited information about, for the lower back pain with the blood flow restriction. Yeah, I'll be interested in that too. So I'm sorry, but I can't answer this, further than this.
Okay, this is the last question. This is from Supradeep Mukherjee. If a person has more congenital lordosis curve, then does it have more chance of lower back pain?
Okay, by birth, huh? Naturally having a lordosis.
Yeah.
So, which means we have more curve, right? I mean, lordosis, we have naturally lordotic lumbar curve, right?
Yeah.
But if it's more in the forward, could be. That's the reason. That's the reason why they have more frequent lower back pain. But at the same time, what we can control is movement pattern, education, and also strengthening, and also preparing athletes for the physical demand. That's all we can do. I mean, Usain Bolt is famously having I forgot the. Oh my god! What's that? What's a tilted spine? I forgot. Not lordotic, but his spine is tilted sideways.
Oh.
So scoliosis. Yes, that's what I was looking for. I forgot. I don't know why I forgot. I didn't use that word for so many years, I guess. When I'm back in Japan. So scoliosis could be also a good indicator for the lower back pain, but at the same time, but again, we control what we can control as a coach, as a clinician. So that's my answer.
All right, Mr. Sasaki, it was wonderful having you. You have given a lot of inputs in regarding low back pain, and your session was really wonderful. I thank you on behalf of Sports Authority of India for having taken the pain to come and deliver this presentation.
Thank you very much.
Again, I hope to be in touch with you for more sessions in future.
I'd love to.
Yes, thank you, Sasaki. Now,
if you have any question, you're more than welcome to add me on the again Instagram, coach_Saki, and LinkedIn. Also, you can find me Yuichi Sasaki, YUICHI SASAKI. Please send me a question.
all right, thank you, Sasaki. Yeah. You can log out now because we are going to have some Hindi session. We have Dr. Abhimanyu who will be summing up both the sessions in Hindi. So those participants who wants to listen to the sum up in Hindi, we ask you to stay back. Yeah, rest of them can leave. Thank you very much. Thank you, Sasaki, once again.
Thank you. Have a good day.
Good evening.
Thank you. Thanks for the opportunity, Dr. Zaju. I really enjoyed it.
Welcome. Yeah.
Sure. Bye.
Bye.
Thank you. Good evening. आज के सेशन में, इस टेक्निकल सेशन में 2 प्रेजेंटेशन हुए और अगर हम पहले प्रेजेंटेशन को देखें जो चीन बुन चोंग ने प्लानिंग एंड एग्जीक्यूशन ऑफ प्लायोमेट्रिक ट्रेनिंग पे बात किया, इट वाज वंडरफुल प्रेजेंटेशन। उन्होंने प्लायोमेट्रिक्स ट्रेनिंग और प्लानिंग का कंप्लीट एस्पेक्ट्स को कवर किया और जिसमें अमोर्टाइजेशन फेज क्या होंगे और उसको कैसे हम स्टेज शॉर्टनिंग साइकिल को कितना रिड्यूस करेंगे और इवेंट वाइज उनके क्या इम्पैक्ट होंगे और ट्रेनिंग के क्या प्रोसीजर होंगे, उन सभी को उन्होंने कवर किया अपने प्रेजेंटेशन के अंदर। और डिफरेंट टाइप के वीडियोस के माध्यम से वो ट्रेनिंग पैटर्न्स को उन्होंने डिस्प्ले किया, जिसके माध्यम से शायद मेरे को लगता है कि वो हिंदी बेल्ट के जो भी पार्टिसिपेंट्स हैं उनको वो मूवमेंट का एग्जीक्यूशन तो जरूर समझ पा रहे होंगे। और उन्होंने उन सारे एस्पेक्ट्स को कि किसी भी प्लायोमेट्रिक एक्सरसाइज को करने में हम जब भी स्ट्रेच शॉर्टनिंग साइकिल को यूज करते हैं तो किस एंगल तक वो जॉइंट मूव करेगा तो उसका इम्पैक्ट किस पर्टिकुलर इवेंट्स के लिए ज़्यादा होगा, उन सारे एस्पेक्ट्स को उन्होंने कवर किया। और चूंकि ये प्रेजेंटेशन ज़्यादा विजुअल था और उन्होंने सारे एक्सरसाइजेस को वीडियो के माध्यम से प्रदर्शित किया, इसलिए मेरे को लगता है कि उसको समझना भी सबके लिए आसान रहा होगा और सबको समझ में आया होगा। तो चूंकि ये प्लायोमेट्रिक ट्रेनिंग पे कल के बाद आज दूसरा प्रेजेंटेशन था एंड इट वाज मोर एलैबोरेटिव और मोर स्पेसिफिक कि छोटे-छोटे एस्पेक्ट को भी उन्होंने कवर किया, तो ये सबके तक पहुंचा होगा, ये हमारी अपेक्षा है। आज के दूसरे प्रेजेंटेशन में मिस्टर यूची सासाकी ने हाउ कैन वी हेल्प एथलीट विथ लोअर बैक पेन in consideration to strength and conditioning rehab purpose से उन्होंने प्रेजेंटेशन किया जो बेसिकली मेडिकली ओरिएंटेड था। स्ट्रेंथ एंड कंडीशनिंग का मेडिकल ओरिएंटेशन था उनके प्रेजेंटेशन में। अगर हम स्टार्ट करें प्रेजेंटेशन को तो क्या रीजन्स हो सकते हैं लोअर बैक पेन के या लो बैक पेन के, वो उन्होंने रीजन्स जिसके अंदर हर्निटेड डिस्क या नर्व इरिटेशन या सॉफ्ट टिश्यूज के लैक ऑफ रिकवरी या लिगामेंट के स्ट्रेन, ये मूल उन्होंने कारण बताया, इनके कारण लो बैक पेन होने की संभावना हो सकती है। और अगर हम देखें तो उन्होंने बेसिकली L4 और L5 के पोजीशनिंग और उसके ऊपर जो पड़ने वाले दबावों के विषय में उन्होंने डिस्कशन किया। अगर तो सबसे पहले उन्होंने बताया कि अगर कोई भी एथलीट लो बैक पेन से अगर उस रिपोर्ट कर रहा है कि लो बैक पेन है तो हम कैसे उसको रिकॉग्नाइज करें, तो कैसे वो चोट लगा उसको, फिर कहाँ चोट लगा और कब चोट लगा, उसके माध्यम से हम उसको रिकॉग्नाइज कर सकते हैं। और क्लिनिकल थिंकिंग की उन्होंने बात किया कि जब भी एथलीट को चोट लगता है तो जो लोग भी क्लिनिकली हैंडल कर रहे हैं वो जो भी उनके एक्सपीरियंस हैं एथलीट्स हैंडलिंग की, उसके बेसिस पे उसके चोट के विषय में जो भी नॉलेज है उसको गेन कर सकते हैं। और चूंकि क्लिनिकल पैटर्न्स में जो भी एथलीट को हम असेसमेंट करते हैं, तो जो भी क्लिनिकल टेक्निक्स हैं उनके बेसिस पे जो भी फिजियोज हैं या जो लोग क्लिनिकली जुड़े हुए हैं वो रिकॉग्नाइज कर सकते हैं। उसके बाद हम उस एथलीट का क्या इंजरी हिस्ट्री है उसके बेसिस पे भी लो बैक पेन को रिकॉग्नाइज करने में हमें हेल्प मिलता है। और अभी जो अभी जिस इंजरी को लेकर वो रिपोर्ट करने के लिए हमारे सामने आता है, उसके वो कब लगे और वो जिस इवेंट्स में पार्टिसिपेट कर रहा है वो कॉन्टैक्ट इवेंट है या नॉन कॉन्टैक्ट इवेंट है, उसके बेसिस पे हम असेसमेंट फर्स्ट स्टेज के असेसमेंट में इनके बेसिस पे हम असेस करते हैं, उसके हिस्ट्री के बेसिस पे, उसके एक्सपीरियंस के बेसिस पे। अगर असेसमेंट के लेवल 2 को देखें तो हम लोकल असेसमेंट कर सकते हैं, जो डिफरेंट डिजिटल मीडिया है, एमआरआई है, एक्सरे है, इनके माध्यम से। उसके बाद ग्लोबल असेसमेंट कर सकते हैं, जो टोटल मूवमेंट पैटर्न उसका एथलीट का है, उसके बेसिस पे हम लो बैक पेन को रिकॉग्नाइज कर सकते हैं। असेसमेंट लेवल 3 को अगर हम देखें तो लोकल अगेन लोकल अप्रोच के माध्यम से उसको हम हैंडल करेंगे, और जिसमें रेंज ऑफ मोशन के बेसिस पे एथलीट के इंजरी को रिकॉग्नाइज हम कर सकते हैं। इसमें सेंसिटिविटी और स्पेसिफिसिटी को हम टेस्ट करने की कोशिश करेंगे, डिफरेंट टेस्ट के माध्यम से, उसके माध्यम से असेसमेंट हम कर सकते हैं। असेसमेंट लेवल 4 को देखें तो ग्लोबल अप्रोच, जिसमें जो भी सेलेक्टिव मूवमेंट्स हैं, जो नॉर्मल मूवमेंट्स हैं एथलीट्स का, उसमें क्या चेंजेस हुए हैं लोअर बैक पेन के कारण या लो बैक पेन के कारण, वो हम जानने की कोशिश करेंगे, और मूवमेंट में क्या डिफिकल्टीज है उसके बेसिस पे हम लो बैक पेन को रिकॉग्नाइज कर सकते हैं। दो थियरी का उन्होंने दो थियरी को डिस्क्राइब किया, जिसमें टेंसिग्रिटी थियरी और रीजनल इंटरडिपेंडेंट थियरी। और उनका ये थियरी ये कहते हैं कि कोई भी बॉडी पार्ट जब मूव करता है तो किसी अन्य बॉडी पार्ट के मूवमेंट के बेसिस पे ही वर्क करता है। जैसे हम कहीं देखते हैं तो देखने के लिए हेड का फोकस उस डायरेक्शन में होना जरूरी है। अगर हेड का फोकस किसी डायरेक्शन में जाना जरूरी है तो उसके साथ साथ हमारे बॉडी को उस तरफ मूव करना जरूरी है। और ये थियरी ये कहती है, अब सीन अगर कहीं मूव कर रहा है तो बॉडी का डायरेक्शन भी उसी दिशा में होगा। तो अगर ऐसा नहीं है तो कोई ना कोई डिसऑर्डर्स हैं, उसके बेसिस पे हम उसको डिसऑर्डर को रिकॉग्नाइज करने की कोशिश करते हैं। लो बैक रिहैब प्लान का उन्होंने 5 स्टेप में डिस्कशन किया, जिसके अंदर के मूवमेंट पैटर्न के माध्यम से हम जब हम उसको रिहैब करने के लिए चलते हैं, तो काम करना शुरू करते हैं, तो मूवमेंट पैटर्न सबसे पहले हम जो करेक्ट मूवमेंट पैटर्न्स हैं उनको डेवलप करना शुरू करेंगे। फिर होल बॉडी के जो मूवमेंट्स हैं और एंड स्टेबिलिटी है उनको सेकेंड स्टेप में रखेंगे जब हम रिहैब प्लान करेंगे उस समय। थर्ड स्टेप के अंदर एंडोरेंस इंक्रीज करने के लिए ट्रेनिंग करेंगे। फोर्थ स्टेज के अंदर स्ट्रेंथ बिल्डअप करने की प्लानिंग होगी हमारी रिहैब प्लानिंग के अंदर। एंड फिफ्थ विल बी द डेवलपमेंट ऑफ स्पीड, पावर एंड एजिलिटी। हम एथलीट को असेस करेंगे और असेसमेंट के बेसिस पे इंजरी को रिकॉग्नाइज करेंगे, आइडेंटिफाई करेंगे। अगेन वी विल ट्राई आफ्टर ट्रेनिंग एंड अगेन रीअसेस। अगर हम फिट लगता है कि एथलीट फिट है, देन वी विल अलाउ टू गो टू द पार्टिसिपेट इन द डिफरेंट एथलेटिक इवेंट जिसमें वो पार्टिसिपेट कर रहा है। और जब हम उसको भेजेंगे तो मेडिकली फिट होना चाहिए उसको, जिसमें वो कंप्लीट रेंज ऑफ मूवमेंट तक अपने मूवमेंट को परफॉर्म कर सके। अगर प्रिवेंटिव एस्पेक्ट्स को देखें तो वो डिपेंड होते हैं कि जिस स्पोर्ट्स में एथलीट परफॉर्म कर रहा है उसका फिजिकल डिमांड क्या है, एथलीट की फिजिकल लिमिटेशंस क्या हैं, उसकी ट्रेवलिंग कहाँ वो ट्रेवल कर रहा है और किस मीडिया से ट्रेवल कर रहा है, देन क्या अवेलेबिलिटी है, ट्रेनिंग की अवेलेबिलिटी क्या है, और ऑल फूड एंड न्यूट्रिशन की क्या अवेलेबिलिटी है। ये फैक्टर्स हैं जो जिसके बेसिस पे हम इंजरीज को प्रिवेंट कर सकते हैं। अब अगर हम रिटर्न की बात करें तो return to participate, return to competition and return to performance. जब भी हम एथलीट को रेडी करते हैं तो वो पार्टिसिपेट करने के लिए रिटर्न हो, जब और पार्टिसिपेट के बाद आफ्टर ट्रेनिंग कंपटीशन के लिए रिटर्न हो, और जब भी कंपटीशन में पार्टिसिपेट करने जा रहा है तो he should be able to perform more than the earlier, जब भी जो भी पहले परफॉर्म कर रहा था उससे अच्छे कंडीशन में वो परफॉर्म करने के हो। अगर हम फाइनली प्रिपेयर जब एथलीट हमारे पास एक इंजर्ड एथलीट रिपोर्ट करता है, उसके कई उन्होंने 3 मेजर स्टेज का बात किया, जिसमें एक्यूट स्टेज, जिसमें पेन तो नहीं है एथलीट को, बट ही इज एबल टू डू नॉर्मल एक्टिविटी एंड ही इज नॉट गेटिंग द पेन, वो एक्यूट स्टेज है। देन द फंक्शनल स्टेज, जिसमें वो मूवमेंट स्टार्ट करता है, जो इजी मूवमेंट्स है, फन मूवमेंट्स है, उनको स्टार्ट करता है। देन द रिटर्न टू पार्टिसिपेट, वो एक्टिविटी में पार्टिसिपेट करने के लिए रिटर्न करता है विद सम रिस्ट्रिक्शंस, एंड रिटर्न टू पार्टिसिपेट लेवल 2, जिसमें वो पार्टिसिपेट करने के लिए रेडी होता है without any restrictions, means we can give all the types of training. इस माध्यम से उन्होंने एक एथलीट को चोट लगने के बाद कैसे हम उसके चोटों को रिकॉग्नाइज करें, कैसे उसको हम बेसिक ट्रेनिंग स्टार्ट करें उसके रिहेबिलिटेशन के प्रोसेस में, और रिहेबिलिटेशन प्रोसेस कंप्लीट होने के बाद ट्रेनिंग के लिए कैसे रेडी करें, इस पूरे कंप्लीट एस्पेक्ट्स को कवर किया। एंड इट वाज, आई थिंक इट इज वेरी यूजफुल फॉर ऑल द कोचेस, दोज हु आर पार्टिसिपेटिंग इन दिस प्रोग्राम। Thank you, sir. Thank you very much.
Thank you, Dr. Abhimanyu Singh. Oh, yeah, it was really wonderful that you have translated most of the things in Hindi. I hope so that it will be beneficial for our coaches. I have some announcement to make. I mean, one of the reason that, okay, which we included this part of physiotherapy, that is strength and conditioning based on that is for especially Mr. Sasaki's session, is that he is actually a strength and conditioning specialist, but then specifically focusing on to the rehab part. Because many physiotherapists I have seen in India that, okay, they only learn more of things in physiotherapy from practical aspects in the what is taught in the college, but then there is knowledge on sports specific training is lacking. So what our strength and conditioning specialists or even the athletic coaches who are involved in sometimes doing rehab, some of the athletic coaches are also involved in rehab. I've seen that. So they should also know about these stages and methods of training. That's why I included this into this strength and webinar session. Then I feel that, okay, nowadays too much of webinar is going on. So it is also putting a lot of stress on the coaches attending too many sessions. I attend almost 6 Zoom sessions per day with SAI Delhi and SAI Bangalore and including this. So it's really taxing me also. So what I have suggested to DG SAI is that we don't have nowadays refresher courses or anything like that. So as a part of education, I have suggested to Director General about continuous sports science education. So we will have 1 session per week. That is something like every Friday around 11 to 12 o'clock. So that will be a free time, I think. Or if you have any time to suggest to me, it would be good. So maybe at the weekend, 1 session probably maybe from sports science, or it may be even from specific sports. And I prefer that, okay, if any of you would like to do presentation, and if you're ready to do some presentations on certain topics of which you have done some research, or you have some the works in terms of training, what you have done, or in terms of competition, what you have planned, it has led to a success, then probably those ideas can be put up into a presentation, and we may have it in future from every Friday. So that will be a experience sessions plus it will be a knowledge sharing session for the coaches. So if you have any ideas on those lines, you can message me. The next thing is that, yeah, I would like to have, I mean, DG is very particular that he would like to have an examination on this strength and conditioning webinar. So it's not just to assess you all, but also to assess whether the foreign faculty, whether we are in a position to cope up with the foreign faculty or not. So that in future, if we want foreign faculty to come into India and deliver lectures, you need to see the understanding level of our coaches. That is one aspect. So of course, along with that, of course, it will also give us an assessment about how much reception has taken place from our people's side. So whether they were in a position to receive the things or not. So it will be like multiple choice questions and maybe for 1 hour or so, maybe around 60 questions or so. So exact date of that, I will let you all know in short while. Maybe next week, I'll let you all know. And the last thing which I want to tell you is, okay, we have a next session on Monday. Tomorrow is Sunday, so it's off for us. So next Monday afternoon, again, we will meet up at 2:15 for 2 lectures at 2:15 and at 4 o'clock. That is at 2:30 and 4 o'clock. So until then, stay safe, take care, and good evening to all. Thank you very much.